Stanford University.
Pleasure to introduce Dr. Chris Newton-Cheh, and Chris is I would say epitomize what a physician scientist should be. He's a clinical cardiologist. He sees heart failure patients as well as cardiac genetics clinic. By way of background, he received his bachelor's degree at Dartmouth and then went to Columbia for his medical school. And then since then, has stayed in Boston. He did his residency cardiology fellowship all at the MGH, and then did a MPH degree in clinical effectiveness at the Harvard School of Public Health. Afterwards, he did a postdoc in genomics at the Broad Institute at Harvard and MIT. And I think it must be there that he learned all these secrets and tricks for understanding the cardiovascular genomics, and was been tremendously prolific in terms of publications, more than 220 publications. He's published in New England Journal, JAMA, Nature Genetics, tons of Nature Genetics papers, Circulation, JACC, and so forth. He's currently an editor associate editor for JACC. And I think Chris has really, if you follow the literature closely enough, you'll see that he's made tremendous impact on trying to understand the genetics basis of left ventricular hypertrophy, genetic basis of QT interval prolongation, which we also have quite a bit of interest in, genetic basis of blood pressure, and also genetic basis of sudden cardiac death. And so it's, and he's been very well funded by multiple all-1 grants as well. So it's really a great pleasure for us to have Chris here and give us a perspective of a topic that's very exciting and certainly for me very dear to what we do in our lab. Thank you so much, Chris, for coming.
Great, thanks so much for the kind introduction. Are you able to hear me okay in the back? Great, and hello, Hawaii. I will be talking today about one area of focus that is not in conflict with anything that I have a financial stake in. My laboratory, as mentioned, uses the tools of population genetic studies as well as genotype-directed studies in both healthy volunteers and patients in the hospital, and some efforts to try to identify underlying molecular mechanisms of genetic variation. We focus broadly in 3 areas: QT interval, which will be the focus of today's talk, because I think it touches on some of the development in cellular modeling. Blood pressure, and the long and short of it is, I can tell you there are 1,000 common genetic variants that contribute to blood pressure, and coming to the precision medicine mecca, I will say you will never be testing your genetic profile to choose an antihypertensive medication. Just give you that's the short version of all of my research on blood pressure. And then in left ventricular hypertrophy and dilated cardiomyopathy. I will try to stop by about 1:15 to give time for questions at the end. But if folks have questions that come up during, I'm happy to have you raise your hand and address it at the moment. So when I started out as a fellow or postdoc, I was interested to try to pursue some genetic studies that might uncover mechanisms that contribute to sudden cardiac death. It's a big problem. Hundreds of thousands of people die annually, commonly due to ventricular fibrillation or tachycardia, although it's not always clear when a patient dies suddenly what the mechanism was. Coronary artery disease is very commonly present, but risk factors are not adequate to identify patients at high enough risk, and it can be the first clinical event in up to 1/3 of those who die suddenly. However, to date, GWASs that I've contributed to of sudden cardiac death have identified no common variants meeting genome-wide significance that were discovered through the study of sudden cardiac death. And I'll touch on the latest among those. But genome-wide association studies of intermediate traits or risk factors for sudden cardiac death have been far more successful, probably generally across the field of human genetics. But I think one can recognize that studying risk factors is not the same as studying disease. Most patients don't experience a risk factor daily, but disease is associated with much more morbidity and mortality. And it's been recognized that QT prolongation on the electrocardiogram is a risk factor for sudden cardiac death, both in the general population and in those with recognized cardiovascular disease. It is thought that at least some of this is mediated through Torsade de Pointe, a specific form of ventricular tachycardia that exists in patients who have abnormal repolarization, specifically that's quite heterogeneous across the myocardium. And it is recognized that any of more than 100 medications can cause sudden cardiac death by, through their effects on altering myocardial repolarization, which is the cellular phenotype that is being discerned with the electrocardiogram on the surface of the chest. And if it's a non-cardiac medication that treats a non-life-threatening condition, such as terfenadine, an antihistamine, or cisapride, a GI promotility agent, and there are alternatives in class, then as a society and at the regulatory level, we don't tolerate more than one event per million. And in fact, these two were withdrawn from the market. Erythromycin definitely causes some sudden cardiac death, but the utility in treating several bacterial infections leads to a risk calculus that keeps it on the market. Haloperidol would be another that is an antipsychotic, and I think antimicrobials and anti-psychiatric therapies include a lot of the medications that are associated with abnormal repolarization. But in fact, it can be the on-target intended effect to alter myocardial repolarization. Medications like sotalol and tafetalide are used to treat and prevent life-threatening ventricular arrhythmias, but they do so at the cost of inducing life-threatening ventricular arrhythmias. And so I'll talk in a little bit greater detail later about these two medications because they have stronger effects on the QT interval, and there may be a therapeutic opportunity there. For comparison, I'll be talking about some genetic variation and the effects of individual genetic variants. I'll point out that when a drug is administered and is associated with mean effects on the QT interval to lengthen it by 8 to 10 milliseconds, this reaches a threshold where the U.S. Food and Drug Administration looks much more carefully, as do pharmaceutical companies. And unless they're treating with a very unique therapeutic effect, such as arsenic to treat specific forms of hematologic cancer, often drugs will fall out of the pipeline once it's recognized that they're associated with a repolarization effect. There are well-recognized Mendelian syndromes in which strong familial aggregation of extreme long or far less numerous short QT interval is associated with increased risk of sudden death from Torsade for the long QT and idiopathic ventricular fibrillation for a short QT interval. These are typically due to penetrant rare mutations and the arrhythmias can be induced by exercise, administration of QT prolonging drugs, or some stereotyped clinical circumstances such as swimming underwater or being awoken by an alarm clock. However, I think we're slowly learning more and more that these are not as penetrant as we thought they were when ascertained in families that aggregate Mendelian arrhythmia syndromes. When unbiased screens are done using genetics first to identify those who carry genetic variation, it's clear that the penetrance is probably lower than was initially suggested. Here's a list of currently accepted genes, but if you want to remember a short list, you could just focus on the first three, KCNQ1, KCNH2, both encode repolarizing potassium current proteins. SCN5A is the cardiac sodium channel. There are beta subunits of those two channels, but these first three explain the majority of explainable congenital long QT syndrome. And I'll focus on just one of these as a start. KCNE1 encodes the beta subunit of the IKS potassium channel, and it's been recognized since the 1990s that there is a common polymorphism that has a frequency of about 1% in individuals of European or East Asian descent that is associated with prolongation of the QT interval. In fact, initially in the 90s, it was thought that this might be pathogenic for long QT syndrome, but once it was recognized that it was so frequent, the frequency of long QT syndrome is about 1 in 2,000, it was not possible that this could be individually sufficient that it causes long QT syndrome. And in fact, we've done some collaborative studies with folks in Finland, where Health 2000 is a population survey, population-based survey, or the Framing MHeart study, which is a community-based survey outside the Boston area, and in two reasonably large studies of QT interval as a quantitative continuous measure in people not selected for having any specific disease. About an 8 to 10 millisecond longer QT interval is observed in carriers of the 85N allele. And so this, if you want to keep in mind the frequency and effect size relationship, this at the 1% minor allele frequency is at about the threshold where if it was a drug that was administered, one would have to consider with greater scrutiny whether the risk-benefit profile might not be acceptable. All right. In early work done in the 90s in small-scale sequencing studies here, 100 individuals with drug-induced ventricular arrhythmias compared to controls. This was an abstract in circulation, although I got most of this from their patent application. I don't think this is currently marketed for testing, but there's about a 7% frequency of the 85N allele in drug-induced arrhythmia cases compared to 1 to 1.5% in controls. A very small study. These are typical of the genetic studies done in the late 90s, early 2000s, when the majority of the findings were falsely positive due to generally overly permissive significance thresholds. There's a suggestion of a modest effect on drug-induced arrhythmia risk. And then in those who were found to have long QT syndrome not due to one of the top 3 genes, it was found that the frequency was about 10% of those with mutation-negative long QT syndrome, again, compared to about 2% in controls. The first 3 bullets here are people of European descent. In another study of individuals of Japanese descent with congenital long QT syndrome not attributable to the top 3 genes, it was about a 7.5% compared to slightly less than 1% in controls. So this is compatible with a model in which this variant has an incremental contribution to risk of arrhythmias, whether on due to other inherited genetic basis or administration of a medication, but by itself, clearly not sufficient to cause disease. In fact, in a candidate SNP study that focused on 18 candidate genes and examined 176 patients who had Torsade de Pointes, that stereotyped form of ventricular arrhythmia, compared to controls who specifically were selected for having had less than 50 millisecond QT prolongation in response to exposure to a class 3 drug. This is a class associated with repolarization delay. The top variant was identified was in fact this D85N variant. It's not a significance threshold that would survive accounting for the entire genome, and I'm not making specific claims, although I'm trying to demonstrate an evidence base that would support a modest effect on QT interval variation or an intermediate effect and a modest effect on arrhythmia risk. And in a small replication sample, the there was not adequate support. But I suspect that the truth is probably would be captured by the meta-analysis of these two. So that's the 1% KCNE1 variance with about a 10 millisecond effect. Now I'm going to talk about our use of large-scale genome-wide association studies to identify generally much more modest effects. This was in fact the second genome-wide association study that identified a finding that was not bogus due to failure to achieve adequate statistical significance. It was a relatively small GWAS using 100,000 variants in 100 women with relatively short QT intervals and 100 women with relatively long QT intervals and successive stages of additional replication that identified a consistent roughly 3.5 millisecond per minor allele effect on lengthening the QT interval. These variants, and there's a set of variants that are highly correlated, are all non-coding, and they happen to lie, I just say, near NOS1AP. I will point to individual genes when it's clear that they're the source, but in this case, we couldn't prove in this study that, in fact, NOS1AP was the cause of the association. And in fact, this variant, or highly correlated variants in people of European descent, are associated with a relatively modest impact on sudden cardiac death, with roughly a 30% higher odds of sudden cardiac death compared in per copy of the minor allele. I'll say this is relatively minor because if the incidence of sudden cardiac death in a adult population between the age of 50 to 80 is about 0.1% per year, 1 in 1,000, then the increment in risk means you go from 0.1% to 0.13% per copy of the minor allele. I think you can appreciate that a 3 in 10,000 increment in risk is not enough to consider taking a beta blocker or implanting a defibrillator. Moreover, it's been found and reported that variants in NOS1AP, highly correlated with the variant I just showed you, are associated with an increased odds of Torsade de Pointe, the ventricular arrhythmia. And so here now, I'll show you some evidence to support NOS1AP's modifying role in congenital long QT syndrome. There's a South African founder population. The challenge of studying Mendelian conditions is they're typically caused by genetic variants that are private to individual families due to negative selection that prevents them from rising in frequency in the general population. But there was a founding event where a Dutch family in the 1700s went to South Africa, and a large family segregates KCNQ1 variant. Up to 205 mutation carriers have been recruited and studied, and in these carriers of all the same mutation, the presence of a NOS1AP variant was associated with increased symptoms, including both syncope and cardiac arrest, as well as increased risk of cardiac arrest, although these are at very modest statistical significance. A separate study reporting diversity of genetic etiologies across Europe also showed an increased risk of cardiac events, and a smaller study in people of European descent showed a modifying effect on QT interval. And throughout, when I refer to QTC, it means that there's a heart rate correction that's been applied to the QT interval. Anytime I say QT interval, I always mean that there's a correction for the heart rate, even if I just use that as a shorthand. There was a trend toward a lower clinical event rates, but it was not statistically significant. So for these two examples, I've shown you a polymorphism with a frequency of about 1%. The NOS1AP frequency is about 20% in people of European descent. And you can appreciate there's a graded effect both on the QT interval and on sudden death. So now we'll zoom out a bit to larger and larger studies that are powered to identify weaker and weaker effects on QT interval. This was one such study that we published in the late 2000s, in which, of course, we rediscovered the NOS1AP variant. You should assume that unless there's some strange selection, that if you identify a variant in a smaller study, you should continue to identify it in much larger studies. In fact, there are common genetic variants at the loci that include the KCNQ1, KCNH2, and SCN5A variants that are genes that harbor rare variation that causes congenital long QT syndrome. But in fact, in all of these cases, these are non-coding variants. We can't formally prove that, that these effects are mediated through these genes, although it seems likely. And this is the largest study to date. We currently have a study that we finished our quality control, and we're just doing the preliminary association testing in about 200,000 people using imputation to the haplotype reference consortium or 1,000 genomes. This will hopefully be submitted later this year. But I'm showing data that were published in 2014. This was a GWAS in 76,000 people of European descent. We did usual adjustments for the effective heart rate as well as female sex. Women have about a 5 to 10 millisecond longer QT interval and have an accordingly higher risk of Torsade de Pointe. And this is using relatively crude imputation with HapMap2 and a fixed effects meta-analysis. So these are the co-authors of this paper, and I appreciated Joe's pointing to the PubMed list of the number of articles I have. I'll say that I think 5 or 6 of them are corrections that are listed as articles, but in fact they're just fixing someone's affiliation because we got it wrong. But this will be the slide where I try to show that, in fact, these studies take a lot of work. They take individual investigators at multiple centers across, in this case, the US, Canada, and Europe. And I'm appreciative of the work. I think everybody who's on this slide gets to present these data as their own, but you can appreciate there's a fair amount of effort herding all of these cats. And here is shown the distribution of the association results in significance space, where we plot the negative log 10 of the p-value on the y-axis. On the x-axis is plotted the expected distribution of the negative log 10 of the p-value when in fact there's nothing going on, that any result that has a low p-value is simply due to chance. In fact, we observe some distortion away from this chance line that is represented by the red line. In fact, 50% of all of our data are present just in this little part of the line because, of course, the majority of our results have very weak p-values. And then if we subtract all the loci that were identified in this study and prior work, zooming out to a megabase on either side, we still see evidence of deviation consistent with the model in which there are at least more variants that than we found in this study. And in total, we identified 35 independent chromosomal regions that harbor collectively 68 independent variants. Some loci harbor multiple variants. And these explain about 7.5 to 10% of variation in QT interval. From prior work in the Framingham Heart Study or in the Jackson Heart Study, we know that in people of European or African American descent that about 40% of variation in the QT interval appears to be heritable. So this is about a quarter of that, give or take. It's not dissimilar to studies in about 100,000 people who had, for example, LDL studied. Usually you can detect about 25% of the heritability of LDL with that sample size. And there were 13 previously established loci I'll highlight a few of them as we go along. I enjoyed meeting with some of the postdocs and grad students this morning. I'll just point out, as I mentioned this morning, SLC881 is the sodium-calcium exchanger. Phospholamban is influential in regulating circuit 2A. In fact, we found circuit 2A in this study as well, which is ATP2A2, as well as protein kinase C alpha. I'm going to come back to a few of those observations a little bit later, but I think it fits with the growing understanding that calcium cycling actually influences repolarization, even though much of the focus has been on potassium and sodium flux. In this study, in a prior study in the CARE Cogent Consortium, we had the chance to do a genome-wide association study. About a fifth the sample size of people of African descent, and we were able to find only a couple genome-wide significant loci that had already been recognized in people of European descent. In this study, we found that 10 SNPs, 10 of our 68 SNPs, met a Bonferroni corrected p-value threshold. If one were to assume due to chance that in fact none of the SNPs were specifically associated in people of African descent, you would expect about 33.5 out of 67 SNPs to go in the opposite direction to what was observed in people of European descent, but in fact we observed 51 out of 67 SNP effects that were in the same direction. And the correlation was about a correlation coefficient of 0.6, meaning that about 1/3 of the variability in people of European descent, QT interval, was observed in people of African descent. Many of the GWAS loci that were identified were non-coding, and under the assumption that some of these non-coding variants might alter expression of nearby genes, we collaborated with Tom Coppola, Mike Morley at UPenn, who are part of the MAGNA consortium, in which they've collected left ventricular biopsies from 177 patients with end-stage heart failure undergoing transplant, in which the heart was explanted, and 136 apparently healthy hearts in brain-dead donors whose hearts were not utilized in transplant. We examined all transcripts within a megabase of 63 of the 68 QT interval SNPs that had been genotyped in this collection, and we accounted for all of the SNP transcript tests that we performed using a Bonferroni correction, and we adjusted for the best or the SNP with the lowest p-value for association with expression to determine that, in fact, the signals that we observed for QT interval appeared to overlap or be correlated with the expression signal, rather than randomly just happening to detect some nearby correlation with an expression signal due to partial LD or linkage disequilibrium. And in fact, for each of these 6 loci, we were able, or 5 loci, we were able to identify specific genes that were either up or down regulated in the presence of the QT variant. And I'll come back to this protein kinase C alpha gene a little later, but just to highlight that, by way of example, that the minor allele of this common variant was associated with an increased expression of the protein kinase C alpha gene, that the transcript association was highly significant even in just a few hundred left ventricular samples, and in fact when we adjusted for the expression SNP, the QT interval association disappeared, as one would expect if they were tracking the same underlying genetic mechanism. We collaborated with Manolis Kellis and Laurie Boyer and a postdoc who's jointly, or a grad student, Chen Wang, who's in their lab. He's now at Columbia doing a postdoc, in which at an early phase of the NIH roadmap epigenomics program, we used the Chrome HMM inferred enhancers to ask the question whether these QT interval SNPs or their tight proxies appeared to overlie enhancers in left ventricular tissue. And in fact, we found that taking these 68 QT interval SNPs, 34 of them, either the SNP or a tight proxy, overlapped a left ventricular enhancer. If you were to plot the likelihood of randomly selecting 68 SNPs from the genome and having those 68 SNPs, this is the histogram plot. You don't ever observe 20 loci overlapping LV enhancers, and in fact, we observed 34, so hence the statistical significance. This does not look like it's from this random curve. We hoped to identify novel long QT syndrome genes. The short answer is we have not, but we examined roughly 300 probands who were free of rare variants in KCNQ1, KCNH2, and SCN5A mutations in collaboration with investigators in Amsterdam, London, the Mayo Clinic, Nantes, Pavia, and Toronto. And we sequenced exons of candidate genes at these common variant loci that we thought were promising: SERCA2A, caveolin 1 and 2. Caveolin 3 had been recognized to be a long QT syndrome risk factor. The sodium-calcium exchange, or sarcolumin in a TRP channel. And we compared these to controls and to the NHLBI exome sequencing project. Today, we would compare these to NOMAD or EXAC for population frequencies. And at the end of the day, I cannot say that any of these mutations that are not present in controls or 4,500 exome sequenced individuals are pathogenic or not. We did pursue 2 premature stop codons, one in SERCA2A and one in TRPM7, but in fact, we were not able to demonstrate segregation in those families. And so the short answer is we have not expanded the number of genes recognized to cause long QT syndrome. We did a basic pathway analysis of genes at the loci identified, and as I pointed out earlier, these highlighted calcium cycling genes as contributing to QT interval variation. I'm not showing you the potassium signal, which obviously is very strong, but is contaminated by our prior GWAS that had demonstrated those. And if you take collectively all of the genetic variants that are identified and you aggregate the individual incremental effects into a genetic risk score, here with a score of 14 SNPs from our first, or I guess our second GWAS, we found that comparing the top and bottom quintile, there was roughly a 15 millisecond difference in a Finnish population study, explaining about 8.5% of variation. When we expanded this to 68 polymorphisms, it explains about 14% of variance. That's a little more than other collections. I think the QT interval measurement in this Finnish sample was a little better than the other studies we had done. And if you take these 14 common variants, you can see they have an incremental and graded effect across the 5 quintiles. On the right axis is the odds ratio for having a prolonged QT interval, what's considered prolonged based on clinical criteria, 450 millisecond in men or 470 in women, as well as the incremental effect on the millisecond scale. So you can see that roughly linearly, the additive incremental effect on QT interval tracks with the odds of having a clinically prolonged QT interval. So all of these first slides are to try to build a rationale that if variants that are detected in QT interval GWAS are collectively associated with resting QT interval and clinically defined QT prolongation, could these be associated with drug-induced QT response, drug-induced Torsade de Pointes, or sudden cardiac death, using the analogy of those first 2 variants that I showed you that have stronger effects on QT interval and modest effects on sudden cardiac death. So we are now pursuing several studies to try to establish this, including studies in which we recruit healthy volunteers who are genotyped for this QT genetic risk score and administered moxifloxacin, an antibiotic that has a 10 millisecond longer QT interval associated with it, to determine whether extremes of the genotype score are associated with incremental effect on QT response. We have an R01 in collaboration with investigators at the Mayo Clinic, Cleveland Clinic, University of Colorado, as well as MGH, looking at inpatients who are hospitalized for initiation of tafetolide and sotalol, in whom we're collecting the EKGs that are done according to the standard 3-day load and testing them for the QT score SNPs. To date, we've recruited 550 patients and trying to get it up to 1,000. We'll be both genotyping them for the common variants as well as sequencing both long QT syndrome genes and genes under the common variant loci. I'll just show you a few slides from a preliminary study. I would call it a pilot in collaboration with David Strauss at the Food and Drug Administration. They had previously administered to 17 people of European descent, 4 African, 1 Asian descent, apparently healthy individuals who were admitted to a clinical research organization and administered single doses on separate days of dofetilide, quinidine, ranolazine, or placebo, with 7 days of washout in between each. And they had, over the span of 24 hours, 15 electrocardiograms and plasma samples for mass spectrometric measurement of achieved drug level. And the QT interval was heart rate corrected and then adjusted for the baseline QT interval, for the placebo effect, and for the achieved plasma drug concentration. So it's about as precise a measure if you compare it to the large, messy population-based studies we had done. And we tested a score comprised of 61 SNPs, and I'll skip over a few of these just to show the highlight result is that the genetic score in people of European descent, there were 17 individuals, explains roughly 20 to 25% of variability in the QT response. It's called QTC slope, but it's really the QT change relative to baseline, relative to placebo, relative to the achieved drug dose. In people of African descent, we only had 4 people. It was too few to be able to recognize real effects. Ignore these borderline p-values. This has to be a chance result. We also found that the QT response to these different drugs is in fact correlated, such that roughly 25% of the QT response to one QT prolonging drug is predictive of the QT response to a different QT prolonging drug, consistent with the hypothesis that there's an endogenous repolarization effect that each individual has. That doesn't mean that it's genetic. Obviously, they've had a lifetime of exposures, and it could have environmental effects that contribute to that within-person correlation. And then because the reviewers pushed us and said, why do we care about the QT response in healthy volunteers, we looked at a study of 200 Torsade cases compared to ancestry-matched controls and found that a higher QT score predicts a higher Torsade risk, explaining about 12% of the variance, but the confidence estimates on this are pretty wide. It's probably between 5 and 20% variance. But consistent with the hypothesis that common genetic variation in aggregate may identify individuals who have a risk of an exaggerated response. And so our hope is that if we can develop an evidence base that supports our identifying individuals at risk, we could identify people who should have increased monitoring or people in whom alternate drugs should be considered. Theoretically, one might enable novel drugs to come to market that have a borderline risk-benefit profile, although I think that's not so likely. But by way of example, isotretinoin is the most effective therapy for acne, but it's teratogenic, and so it's only prescribed to women of reproductive age if they have a negative pregnancy test and are taking effective birth control. One could imagine such risk mitigation programs if there was a strong repolarization risk for a drug that had a unique in-class effect. All right, I'm going to skip the sudden cardiac death work, except to say a genetic risk score of 50,000 genetic variants has a statistically significant effect on sudden death risk, but so does a risk score for systolic blood pressure or body mass index or LDL cholesterol, as one might expect from the heterogeneous inputs that contribute to sudden cardiac death risk. And in order to be able to answer questions, I will skip to my punchline, which is that intermediate myocardial phenotypes have offered well-powered quantitative readouts of fundamental biologic processes, and they may expose a liability to a pathologic response to environmental and therapeutic interventions. I have only mentioned a few of the people involved in this work. Collectively, it's over 500 people who've contributed to all of this research, and I'm happy to answer questions from the audience.
Questions? Answered about some of these areas. One of those variants. White blood cells. Among the variants, like you tried to filter to see those genes that are expressed in cardiomyopathy.
So we have, and we do continue to look. I think 5 years ago, I thought optimistically that maybe we could use iPS cell-derived cardiomyocytes and tease apart causal mechanisms by genome editing in individual variants to try to prove which variant at a GWAS locus might be causal. But I'll tell you, these effects on QT interval are so weak. I think the evidence to date suggests that bona fide long QT syndrome coding variants in KCNQ1, KCNH2, SCN5A can have repolarization phenotype in such models that are distinguishable from isogenic genome-edited controls. But I think to parse these genome-wide association loci with very modest effects, I think the cellular phenotypes are going to be sufficiently modest that it may be challenging. So the short answer is yes. We have looked at expression profiles in cardiomyocytes, and at least half of the genetic variants that we've found appear to overlap at least LV enhancers and are
Stanford University.